UBC, inspiring Uganda.
Good evening and welcome to Behind the Headlines. My name is Timothy Nyangweso. In the past few years, cancer has had to become a burden for this country, especially in the previous few years there. We look at the numbers between 35,000 and 36,000 annually. It has been going on an increase, especially affecting women. Children, women, all of them have been affected. Do you have someone that has been affected by cancer or a loss in a family that has been able to be diagnosed as cancer there? We look at cancer today and be able to see 30th August, there will be a cancer run by Rotary. What does that mean for us as a country? How much effort is government putting to ensure that Ugandans are healthy, to become productive for the development we desire as a country? We put government to the sword to answer the question, how much are they doing? But also, Rotary has been doing this for the last 15 editions. This is the 15th. We ask ourselves and find out the answers to these questions. Let me introduce the panel that is with me this evening. I'll start with my immediate left. Anne Nkutu, who is a board member of the Uganda Rotary Cancer Run program, is with us this evening. Good evening, Anne, and it's good to have you.
Good evening, and thank you for inviting me to this program.
The only challenge, I didn't get one that fits me. So what are we going to do about that?
You will certainly get one at the end of this show. But I was saying thank you for inviting me.
Yes.
I grew up watching UTV. And this is my first time to be in the studio, so I'm excited.
Okay. Good to have you. Mm-hmm. Next is a man who has been at the helm of ensuring that Ugandans survive even in the fight of cancer. Dr. Jackson Oriem, the Executive Director of Uganda Cancer Institute, is with us this evening. Doctor, it's good to have you, and good evening.
Thank you, Timothy, and a very good evening to you and to our dear viewers.
Next is Professor Juma Waswa Balunywa, who is an economist, who is a member of SEC of the NRM, but also a philanthropist that looks forward to education and leadership in this country. Good evening, Professor, and it's good to have you.
Good evening, Timothy. Thank you for having me. Something very exciting in the science side where you know I'm not, but in the social side, I'm familiar with.
I see the sneakers are ready, the kit is ready, so we'll be together Sunday?
Yes.
Okay.
Right.
Lastly but not least, Dr. Ayume Charles, representing the people of Koboko, and also the Minister in charge of primary health care. Good evening, Doctor, and it's good to have you.
Good evening, Timothy. Good evening, viewers. It's an honor to be on UBC.
Thank you very much. Let's jump into the questions and also some of the queries that you'll be having. But before we get into that, let's show you some of the statistics that happen in this country year on year. And we'll start with the records of cancer in the country. And you see the numbers there on your screen. It's showing you how it has been growing in the past few years between 35 and 36,000. And also it goes on further to show you what the burden looks like in this country. Most of the people that pass on, about 80% of them that have got cancer pass on because of what happens in there. Finally, we also look at what Rotarians have been doing to ensure that this cancer run happens and also tries to save as many lives as possible. We look at how they have organized this for over the years, since 2012, but also how much money has been contributed towards this. The questions are, how far has it gone in saving lives and what impact has it had on Ugandans there? So those are the areas we'll be diving into, but also we'll be asking questions towards government on what more can be done. You can be part of the show. Join us on our YouTube channel. Let us know what you think. Also, we're streaming live on X. Get there, drop your comment. But the number for text or WhatsApp is 0709 60 25 92. Let's dig into this conversation. And let me come to you first and foremost. The 15th edition. Yes. Come Sunday, the 30th, we're going to congregate at Kololo Airstrip to be able to put a cause to this, put our money to save lives. Why do you want Ugandans to come behind you to be able to give their hard-earned money for such a cause?
The reason that we want Ugandans to join us for the cancer run on 30th August is simply because cancer affects all of us. I doubt there's anybody out there who has not been affected by cancer in one way or the other. We've all lost a loved one, a friend, a family member, a relative.
Yeah.
And so cancer affects all of us. Now, because it affects all of us, then it requires that we act collectively to fight this beast of cancer. As you've said, we've been doing this for the last 15 years. And over the last 15 years, we've made some strides. In our first 3 editions, we raised money that enabled us to establish a cancer center, a cancer ward at Nsambia Hospital. And that has been going on, it's in service, and patients are able to access a cancer treatment in Nsambia Hospital. We, from the Cancer Run profits, we contributed some money to the Rotary Blood Bank in Mengo Hospital. As you know, blood is a key component in the treatment of cancer. Since 2016 to date, we have raised over 9 billion shillings just from the run. And we are in the process of establishing a radiotherapy center. Now, Dr. Jackson will tell you that a radiotherapy center is not a cheap thing. So we are in the process of constructing the bunkers, and we are hoping that these bunkers will be complete and it will be commissioned, the center will be commissioned in December 2027. That is our target. After the commissioning, we will then go in to put in the equipment. And so we'll then have a one-stop cancer treatment center at Nsambia Hospital.
Thank you. Let me come to Dr. Jackson. Doctor, you have been at the helm of this fight for donkey's years. You have seen the good, the bad, and the ugly. What is the state of the Cancer Institute right now, and how many people have been helped in there?
Thank you very much, Timothy. I think as a starting point, I kind of did a bit of reflection on the theme for this evening. And one thing which I want to add, apart from just understanding the burden and what is being done, I think the question of doing it right is very important. And I think in this regard, of course, my Honorable Minister will tell you that for all these years, the government of Uganda has been setting up policy direction for this, and then, of course, also making sure that the implementation arrangement for controlling cancer is in place and is done right, and then, of course, mobilization of the resources. But what is most important, which the government of over years done, has been the establishment of the Uganda Cancer Institute to kind of focus on cancer as a new problem which has emerged in the country. And why I would say government thought that way is just simply because if you look at our health system, the way it is set up and how it was established, it has been mainly on the backbone of what we call communicable diseases. So that means we have a vehicle which is actually geared towards malaria, tuberculosis, and all those other diseases. And this has been like that from the colonial time. But now, WHO will tell you that we have, in Africa in particular, what we call a double burden of disease. What does this mean? This means that in addition to the traditional communicable diseases that we know, now we have the non-communicable diseases. And the non-communicable diseases, one of their characteristics is that they are really complex. And that means there is need for us to have also a fit-for-purpose mechanism for managing them. So for that matter, the government of Uganda actually kind of thought ahead of time and established the Uganda Cancer Institute to kind of handle that. And that is because if you ride on the backbone of the communicable diseases system, which is actually what our health system is all about, then you are not going to succeed. So the Uganda Cancer Institute has kind of been empowered by the legal mechanism so that it can focus on only one thing, and that is cancer in the country. And it should, according to the law which establishes it, design and devise mechanism of fighting cancer. And we call that the establishment of National Cancer Control Plan. And that is actually a policy vehicle. And the Uganda Cancer Institute, as I speak now, has come up with that. And as you know, the purview of policy is with the Ministry of Health. But our law kind of empowers us to devise and then pass on for the policy implementation to the Ministry of Health. And that is now in place. It's a very comprehensive means of fighting cancer, and that means there is the element of prevention, the element of treatment, and then the element of ensuring that there is good quality of life for our cancer patients. And we call that in most cases palliative care. So all that is actually within the National Cancer Control Plan, and that is in place. The other thing which has been accomplished by the Institute is setting up what we call a comprehensive national cancer treatment mechanism, and that includes infrastructure, equipment, as well as the development of the requisite human resource capacity for doing that. That is already also being done, and it is in place. Yes.
Dr. Jackson, in the last 5 years, let's give it 5 years, because we look at that in that 5 years. What has the burden been like for Uganda Cancer Institute, especially with patients? Most recent records show overwhelming numbers that some of them are lying on the floors. Give us a true picture of what is happening, but also where have we come from and where are we?
I should start from where we are coming from. We came from nothing. If you talk maybe about 20 or even 10 years ago, there was nothing to talk about, because even the Uganda Cancer Institute, the way we know it right now, was not in place. But as I speak now, there is a system in place which is actually now helping our population, because in the past, even if a diagnosis of cancer is made, there is nowhere to go. But right now we have a place to go. So the overwhelming number you're talking about is just simply, I would call it a response to the fact that government has put in place now a system where people who are diagnosed with cancer can go and have care. And that has actually also been supported by funding from government. The government of Uganda, probably in the entire East African region or most of the sub-Saharan African countries, I don't know of any other country where cancer treatment is actually provided at the highest level, free of charge, outside of a budget that is provided by a government. And that is happening right now. And I think possibly that is the reason why the numbers are actually increasing, because people are coming and they have a place where they can go and they can get their treatment. Yeah.
And we'll come back to that, the part of funding, but also the part of human resource. Professor, let me come to you. Especially this is a sweet and bitter, because the run is raising awareness, raising money, but also there are people that are coming from all corners of the country. The latest I saw was someone coming all the way from Kenya to receive treatment here because it's free. What does that mean for the social services, especially in health, towards the Ugandans?
Well, of course, first of all, it's important to appreciate the Uganda government over the years in terms of the health service it has given to the ordinary people. Of course, it is now overwhelmed by the growth in population, and from the economic side, the growth in population has not, the growth in government revenues have not yet matched the growth in population. We have a huge young population that is not productive. So government has a huge burden of providing social services, especially health, to this very big population. And what is happening at the moment is that the risk factors of cancer going into the poor people are going to make it worse than what we are seeing at the moment. So government needs to continue on this drive, especially creating awareness among the young people, because today you're going to find some children with cancer. Of course, those are unique issues, but you are likely to find cancer more with the elderly, and then those who are exposed to the cancer-causing factors, the risk factors. For instance, people want to enjoy the chapati and the egg. What is it called? Rolex. Out of, I mean, you find somebody is reusing the oil again and again and again, and people eat it and enjoy it. Now that exposure over time is a problem to this very large number of people. And interestingly, I have found some people thinking that cancer is witchcraft. I mean, you see, there is this thing which says faith begins where knowledge stops. So if somebody fails to understand what cancer is, he leaves it to God. And in most cases, that witchcraft is part of that arrangement. So we have a big problem in the population, within the social communities, that cancer is not understood. People are exposing themselves to risk factors which cause cancer, so we're going to see more people, more numbers, and yet government is not in a position. I have heard, and maybe the minister will talk about it, of an insurance. I think this won't work in a country like Uganda. In small institutions where especially the business sector, the insurance is okay, the medical insurance is fine. But for the population that is not employed, that has no salary, this is a problem. So to me, that huge number of people in society which is growing, creating awareness will be the most important. And the run is such a big thing about creating awareness about cancer.
But you have caused an itch, so let's scratch it and get it out of the way. If you're talking about national insurance, how is it working in Rwanda, and you're talking about it not being able to work here? We seem to have the same environment in terms of employment and economics.
Insurance, third world countries have to reinsure with the big companies. So if you collect money from us as insured people, we don't have capacity for reinsurance. So a bit of that money will go abroad. And that's number one. Number two, the people who can afford medical insurance are employees who are being paid a salary. I mean, it's like talking about retirement in a country like this, where a very small number of people are employed and retire. So where do you expect the millions of farmers to find the money when they are producing for self-consumption to buy medical insurance? Right now, the arrangement by government to provide these medical services is sufficient. What you need is more awareness to prevent the diseases rather than think about medical insurance.
And we'll come
it's
to that.
It's a business.
We shall come to that in a short while. Let me come to the Honorable Minister. Honorable Minister, when I look at the last 3 budget cycles, health is between 6 to 8% of the budget there. Is that adequate funding, especially with the growing population and looking at the burden of disease? If we're to mention just cancer, is that adequate enough? Is government putting its mouth to save the Ugandans that it needs to be able to develop this country?
Thank you very much. I think at a point in time I'll give my opinion on insurance.
Yes.
But yes, 6 to 8% is not significantly enough. Abuja will say 15%, but I think if we are modest, we could still work even under 10% From where I sit, there's a lot of wastage. There's a lot of pilferage. There is absenteeism. By pilferage, I mean theft of medical stores.
Yes.
And equipment. Absenteeism, you find people in double employment and things. So if we plug all those, because from professors' bit, they can actually cost the amount we lose in terms of pilferage, in terms of absenteeism, and so many misdiagnosis and all those kind of things. And if you plow that back in, I think we could probably get about 10%. Corruption is one of them. But yes, the health sector, I think, is one of the most capital intensive, equipment intensive, health workers, the health workforce in terms of training, but even the scope in terms of numbers. You cannot put a hospital there, even with all the advancement in AI and robotics, and leave it there, put drugs and say clients go there and you'll be treated. It's not like a water pump or a borehole or a school which operates 8 to 5. I think Mulago Hospital from its inception in 1962 has never closed. It's like a police station. So you have to be very deliberate about investing and reinvesting. There are new threats, there are epidemics that come out that can skew you from your intended objective that year, your strategic plan. So we definitely need to keep on stepping up. That 6 to 8%, we can do better as a government. But just to also tell you what my director of Uganda Cancer Institute said, 20 years ago, there was not much we were offering as UCI. The time when I was a medical student and I went through my rotation at UCI was a department. It was a department under Mulago Hospital. I think receiving a paltry budget of 350 million shillings. But right now it's been set up by an act of parliament, the UCI Act of 2016. It has its own hill, and there's a lot on that hill. I would interest you to go there in terms of infrastructure, the equipment. The training is work in progress of oncologists. I think that time there were only 2 oncologists. The late Dr. What is his name? He was the head of the cancer department and doctorium. But right now there's a deliberate effort by government to train young oncologists, and then we have started unpacking the center by setting up regional oncology centers. We've done one in Gulu, and just 2 days ago, Cabinet unanimously passed a loan request of, I think, 33.4 million euros to set up a new oncology center in Mbarara. I think last year Parliament passed a loan request for setting up one in West Nile and Mbale. So there's been a deliberate effort by government to unpack the center and push oncology services to the region. So there's work in progress.
And that brings me to the question, especially, and progress is really good because you're speaking about depopulating the center. What has informed those regional centers that you are driving money to? What has informed the decision to be able to go to Mbarara, Gulu, and Mbale?
Mbale.
So what has informed that by government? Is it the numbers from Dr. Jackson? What has informed it?
No, there are a couple of reasons. Number one, when we are providing services as a ministry, as government, also in the party manifesto, we look at equity, equity to access. You cannot have oncology services in Uganda and then there are a bulk of your population lives up country. There are people in Moroto, there are people in Koboko, there are people in Kisoro, Kabale, Kanungu, and so forth. And when you look at the turnaround time of coming for treatment, you're on chemotherapy, then you have to go back to Kisoro or to Moroto. Those are the floor cases that you see at UCI. Somebody finds it fit to sleep on the veranda or to hang around Mulago Hospital until his next chemotherapy cycle. So there are a number of factors, but then also too, the economy has grown. We are now able to afford this very expensive treatment. The amount of money we put in the physical infrastructure and then the equipment, it's not an ordinary hospital, it's actually a specialized hospital. So, and that's why we are borrowing as government. So the economy has grown and has also given us that depth to be able to regionalize. But then also, like the director said, what was probably falling through the net as witchcraft and as all these myths and misconceptions, our grassroots healthcare systems are now being able to push it up and refer it. And that has been deliberate building of our referral pathways. And we now have a cancer registry, and we're able to map where our threats are and which regions have the highest burden, and also by the type of cancer. So I think it has been driven by a number of factors.
And I like that Doctor is nodding to what you're saying there. But my last question to you, Honorable Minister, is isn't it an indictment to government, especially when Rotary comes around and for 15 years they're carrying this burden to a tune of about 9 billion shillings? Doesn't that put government in a very delicate situation, especially not to meet its obligations to its people?
No, we thank Rotary for stepping forward, and as government we don't take it for granted. They have been our partner not only in cancer, but even in reproductive and reproductive health, maternity, child health services. I think a month ago, one of their district clubs was handing over, I think, equipment for reproductive health services for 14 districts. So I think over the years, it's not the first time that they have stepped forward. But also, service delivery cannot be left to government alone. Government provides the legal framework, government provides the superstructure, but we want to see an economy that is private sector led. And so Rotary stepping forward is not something unusual. There are other areas where the private sector has stepped forward and has been able to contribute a big service. Like the telco industry, the banking industry is actually private sector led. So I don't think it is anything unusual for them to come forward.
And my question will be twofold, but let me start with one. What informs the cause behind a run? What informs the cause for Rotary behind? What drives that cause? Why do you put money to a cause? What informs it?
Thank you, Timothy. First of all, I'd just like to, for those who may not know, Rotary has been around for 121 years. It started in the US and then has spread across the world. Now, over the years, as an organization, we have devoted our energies to what we consider to be the most pressing challenges in our community. We have 7 focus areas that we work around: basic education and literacy, disease prevention and treatment, maternal and child health, economic empowerment, environment, water and sanitation, as well as peace and conflict transformation. So in each country, the Rotarians in that country determine some of the most pressing challenges for them, and that is where our efforts and our resources go to. Now, you may be aware, and I think Dr. Jackson will confirm it, that over the years, cancer has become the leading cause of death among the non-communicable diseases. And cancer is that kind of, it's a very insidious kind of disease. It's not just a medical problem, but it's also an economic burden. You know, you've heard many times people saying that the average Ugandan is one crisis away from poverty. Now, that is, I think, so true when it comes to cancer treatment. It is so expensive. And I think that perhaps is partly the cause why we lose so many people. I was looking at the statistics, and the statistics showed that 60% of the people who are diagnosed die within the same year of being diagnosed.
Wow.
For the simple reason that most of them come late. It's late diagnosis. And we know that there are many factors that contribute to late diagnosis, but we also know that finances, access to affordable healthcare is one of the things. So people get all sorts of treatments until nothing is working, and then finally the diagnosis comes and says, this is cancer. So for us as Rotary, we decided to take up this cause to really complement the efforts of government. We see ourselves as a partner to government. We are never in competition. Government takes the bulk of everything, but we just come in and complement its efforts. And so we took on this because we realized that the Uganda Cancer Institute had a huge burden. And in spite of us establishing the center, you still hear how much goes on at the Uganda Cancer Institute. And so we are just coming in to try and alleviate in terms of increasing the number of centers where people can access cancer treatment, but also hopefully making it a little more affordable. Because I'm sure the more centers that we have, the more oncologists that we have, probably it will bring the cost a little lower. And that is what we are hoping to achieve with our center in Zambia. But I just also wanted to add that one of the outcomes of our cancer run over the 15 years has been the establishment of a program. Because you know the cancer run is annual, but it's a one-day event. And we use it mostly to ramp up awareness, get more people to be aware about cancer. We use it as a resource mobilization tool. And I must say that over the years, we've been able to get so many partners, starting with Centenary Bank, who's been with us right from the beginning, to the Parliament of Uganda, to Crystal Water. There's so many. If I start mentioning them, I risk forgetting a few. But we've been able to bring more partners on board who recognize the burden. And as you said, private sector led. We're getting more and more people through the cancer run from the private sector who are supporting this cause to complement the government efforts. And so we are using it to mobilize resources to increase awareness. But as I said, the cancer run is just a one-day event. So we've since established the cancer program, and that's the board on which I sit. And this is what now drives our efforts around cancer throughout the year. And apart from the run, what we've undertaken provision of screening services, particularly for cancers like prostate cancer, cervical cancer. And so we have mobile clinics that go around the country offering free screening services. We have our medical camps. And within those medical camps, we've also integrated cancer awareness so that people are educated, because knowledge about cancer, unfortunately, is still limited. People still talk about it in whispers. And so people do not even know as much as they should. Many people do not know that it can be prevented. or at least we can reduce the risk factors. Many people do not know the symptoms. Many people do not know where to go. And so through this awareness, we are able to do that. And so we are building on the range of services that we offer throughout the year to be able to, for lack of a better word, mitigate the cancer burden.
Lastly, before I come to Dr. Jackson, how do you find the balance between a brand event, you mentioned your sponsors, all of them that are there,
yes,
and the humanitarian cause? Because I want visibility as a brand that is coming to you.
Yes.
So how do you balance my brand
yes,
versus the humanitarian cause that you're championing?
The Cancer Run by itself has now become a very strong brand. That even though we have partners coming on board, even the partners are interested in being associated with the cause. So it's not just enough for them to have their logos. As you know, increasingly, with the ESG and CSI requirements,
yes,
most of the private sector companies actually want to demonstrate that they're doing good in the world. And that's what Rotary is about. So we become natural partners in this. At the end of the day, we want our brands to be associated with the good that we're doing, with the change that we are contributing in the communities, and not just our logos for the sake of it.
Thank you.
Now, when you come for the Cancer Run, it may appear like a fun event. It is a family event. People come in with their families, there is music, there are all sorts of things. So for a moment, you may think that, is this a fun event? Is it just about brands? But as I said, we're creating awareness, we're offering services, we're raising resources. And most importantly, and I shouldn't forget that, we're also honoring the memories of people who've lost the battle to cancer. And we're walking in solidarity with those who are fighting it.
Thank you. You've gotten to the emotional part there. Let me come to Dr. Jackson. The Honorable Minister mentioned, you have records that show the mapping of what our cancer burden looks like by region, by district. Paint us a picture what it looks like and what are the most types of cancer that are faced by the country.
Yeah, so thank you very much. I think we deliberately took that exercise of doing a mapping of the different cancers in the country. And what we have found out is that overall, of course, the first 5 common cancers generally in the country look similar in the different parts. But there are certain subtle differences that we found out. For instance, if you went to the West Nile region, you'll find that, of course, cancer like cancer of the cervix will still be the first, but you'll find that cancers like that of the liver kind of pops up. And you may not find that when you go to the eastern part of the country. If you went to the western part of the country...
What informs that difference that you've mentioned, West Nile and the east? What informs that difference?
I'm coming to that, yeah. If you went to the western part of the country, you'll find the first, like cervical cancer will be number 1, number 2, prostate, and then you'll see a cancer like cancer of the stomach jumping up there. And then if you went to the far western part, the mountainous region, like in the Kigezi area, you'll see skin cancer jumping up. So that means there are some subtle differences in different types of cancers in the different parts of the country. Now, what actually brings that is there may be some risk factors that may be as specific to those regions that we now need to focus onto. So our first priority was to get the numbers. We have got the numbers, we know the numbers. The next thing is to kind of find out what are the reason for these subtle differences that are coming up, and we call those risk factors. And then, of course, looking at the national level, we should also now come up with an understanding of these risk factors at the national level. The reason why that is very important is if you are going to target cancer prevention, you must look at those risk factors. And there are some that you can modify, there are some that you can do something about, like vaccination. Some may be just simply modification of lifestyle. We want to understand all that, and that will inform our, I would call it interventions, so that the interventions are targeted. For instance, now we are setting up these regional cancer centers. If we have a regional cancer center, for instance, in West Nile, and we are not going to beef it up to handle the subtle difference I mentioned, like cancer of the liver, then that means actually we are not having a targeted approach. The same you'll say for the northern part of the country, the same you'll say for the eastern part of the country, and of course the western part of the country. So that is actually what is informing government intervention. And I should add that as a government, we need to come up with all this documented very well, so that we can help our partners also when they are joining us in the effort of preventing and controlling cancers. We are all singing from the same hymn book.
And Anne mentioned something, late diagnosis, mentioned something on finances. Touch a bit of that, because why are people coming late, but also how affordable is the treatment of cancer when a person has to leave, say, where I come from, deep in Busia, and comes to Kampala, has nowhere to stay, has no one to feed them. How affordable or how manageable is this whole treatment of cancer?
That is a very good point. The first thing which I want to say is that what is causing the late presentation, actually for the most part, has been about lack of awareness. In most cases, the population is not aware about cancers, and you'll even be very surprised that even among our health workers, especially those ones who have been trained in the past, where non-communicable diseases was not really emphasized in the syllabuses and the programs in the training institutions, making a diagnosis of cancer comes as an afterthought, you know, and that in itself, because somebody presents to the medical system, but it's just moving around some infectious diagnosis, they talk about this, they talk about that, and then later they say, okay, cancer might be a possibility. And that means even if a patient presented early to the health system, just because of that moving around within the health system is enough to make the disease to progress. So that is actually one of the issues. But the other issue, which is also very important, is because in most cases, you know, our population, people are poor. And if the diagnosis is going to be in Kampala, or the referral is going to be to Kampala, by the time somebody mobilizes resources to kind of come to Kampala, the disease would have actually progressed. So that in itself is a factor. So one can say that one of the biggest challenge in the management of cancer or in the control of cancer in the country are those socio-economic problems that are actually, I would say, barrier to access to care, and also barrier to maintaining a patient within care. So even if somebody presents early, because of those factors, you know, the disease will progress, and at the end of the day, the outcome is actually still the same. So the whole thing must be handled in an holistic manner.
Lastly, before I come to Professor, what is the ratio of doctors to the patients? What does it look like now at Uganda Cancer Institute?
That is also a very good question. Of course, already we know that our patient to doctor ratio generally is very low. But now if you are to talk about the oncologist to patient ratio, that is even much lower. So that in itself is actually an issue.
and we'll come back to that. Professor, let me come to you. You handle this area of economics. You know how the status is, especially when we say income or disposable income of a Ugandan. He has mentioned something very critical. By the time someone puts resources together to come and get this treatment, what do we need to do moving forward? That now this mapping is there, how can Uganda Cancer Institute, the Ministry of Health, build awareness within the public to understand and appreciate this?
Recently I was talking to some groups of people about retirement. And one of the challenges that comes up with retirement is health. Many people don't mind their health as they change. And by the time they retire, they find retirement very expensive from the health perspective. And we are now arguing people in the HR to let people know that retirement is something you must do, and health, keeping health is one of those things that you must put your effort on. Now, cancer, among the causes is old age, I believe. As the body reduces, the body starts slowing down. So a large number of people who die of cancer will be old age, if you are blessed to get there. The other one is the risk factors which the doctor is talking about. There are a variety of risk factors that contribute to cancer. And I think it's important that people are aware that cancer can come to you in your old age, and like retirement, you need to be ready for it financially. But it's very rare for people to think about retirement until when they are 50-something. That's when they start thinking, oh, I may be retiring very soon. And in the meantime, they've killed their bodies with foodstuffs which are, go against what cancer would require, not exercising at all, and they are in such bad health. So they are prone to cancer attacks. And I'm not a scientist, but I know, I don't know whatever it's called, mutation, something like that. As you grow weaker, these cells become, the cancer cells become more parasitic on the other cells. But people need to prepare for old age in terms of health, which will then take care of not only cancer, but other diseases that may come in, pressure, diabetes, and all the others. But so to me, the run should be pronounced in such a way and promoted in such a way that even the young people are told, one day you may be the victim, because when you're young, you don't know. I mean, cancer is not yours, diabetes is not yours, heart failure is not yours, retirement is not yours. So people will not be able to find the money if they are not aware that this may be a problem, But my other concern is more to do with those people who are not salaried, people who produce for self-consumption, because they really have no savings at all. Luckily, they are the type who are not prone to cancer attacks unless if it is genetic, because they don't indulge in the, I guess some of the risks is highly processed foods. They're not prone to these because, they eat their cooked matoke, they don't use plastics, they have no, they're not exposed to microwaves, all these. So in a sense, that community which is poor, again, is less prone to cancer. But on the other hand, they don't have the resources. We are kept by the family system. The extended family system is what keeps people, and even today, as we speak now, somebody is telling me their father may be taken to India by the larger family system, rather than that person having saved the money. So, in a sense, for the ordinary people who are not educated, who don't have an income, as long as they don't get exposed to the risk factors, they may not get cancer.
Thank you. Yeah. Lastly, let me come to the Minister. The area of awareness, you have mentioned the mapping, you have mentioned what Uganda Cancer Institute, what you're doing as government, but the area of awareness is where the government is having a deficit. Why aren't we promoting this a lot to give the knowledge to people? Because as Dr. Jackson has said, people come late for diagnosis, people are trying to mobilize funds. Why aren't we putting a lot of effort in awareness as government?
I think my answer would be two-pronged. Firstly, we are trying to promote awareness as a country. The cancer run in itself, besides raising resources, creates a lot of awareness for the last. I'm sure everybody who comes to that run appreciates why they are running, at least more than 90%. Secondly, as government, as a ministry, we have a department for health promotion, and part of health promotion includes the health education. There have also been efforts by the ministry. I think we have the physical fitness day, and I think it was launched by the president a few years ago. All those in itself speak to awareness. Number two is on the side of Parliament, because Parliament is an assembly of people's representatives. We have come up with a number of pieces of legislation that speak to awareness, directly and indirectly. If you look at the Public Health Act of 2022 as amended, it was purely an act of infectious diseases. But when we amended it, we had a deliberate insertion on non-communicable diseases. So there's a section, meaning it's now enshrined in our law. We have the Tobacco Control Act, which spells out the what tobacco does, and of course that speaks to cancer, because there's a correlation between tobacco smoking and cancer of the lungs and cancer of the esophagus. We have the Traditional and Complementary Medicines Act of 2018, because we noticed that we had to coexist with herbalists. They are the good guys and then they are the bad guys. So we're trying to show that those well-intentioned herbalists, there's a section where you should stop. Beyond that, it is conventional medicine, because you find herbalists coming, when you jump into these buses, talks about drugs that can heal erectile dysfunction, smelly feet, heart diseases, cancer. There's nothing like that. Let's be a bit sincere. Probably the word of God. Yeah, so there are acts of parliament that have been deliberately put in place to create awareness, but also protect the people, including the Atomic Energy Act. Dr. Riem would not have been able to set up that infrastructure, the bunkers, what we're trying to do at in Zambia, bunkers for the linear accelerators and all that, without that act of parliament. Because the Atomic Energy Council Act spells out the conditions of machines that emit radiation, from CT scans, from the Linux, the X-ray machines, and so forth. Yesterday, you saw the Minister of Agriculture, Honorable Frank Tumwebaze, laying for the first reading the FARA bill. That's the Food and Agriculture Regulatory Authority Bill, 2026. Because we all appreciate that food is one of the predisposing factors. Certain foods are part of the predisposing factors of cancer. There's the food itself, but there's also the way we store our food, the aflatoxins. If you look at most of the food stored in these homes, they have mold, what we call mycoses, and then aflatoxins. All those are predisposing factors for cancer. And probably when you think about it, the reason why maybe our forefathers and traditionally grain was stored in granaries off ground and a bit aerated, other than keeping rodents away, was to give them that aeration, which we don't see now in the houses. And that is a predisposing factor for mold. So to answer your question, there are a number of, it's not one size fits it all. There are a number of attempts by government to create that level of awareness.
And I like that you're talking about, you know, the policies, the laws that are being done. At what point do we leave the books or the paper and get to put someone like Dr. Jackson in front of that screen and say, the following are the problems? Because what we're elaborating here, there's a class that is appreciating it. But the people that the professor is talking about, hand to mouth, really just want to hear as simplicity as possible. How does government leave the paper and get to mainstream media, TikTok, Twitter, and meet its population where they are?
I think this is one of the pathways. And the 2 hours we are spending here is an attempt to create awareness about cancer, not predominant, at least that's what I got through the invitation, not only about the cancer run that's going to happen on Sunday. But yes, I think awareness also begins with us leaders, right from His Excellency downwards. No doubt on his side, he's been a champion of any public health initiatives, whether it's epidemics, whether it's non-communicable diseases. I think he's our biggest champion. Next, it should go down to we as cabinet, it should go down to members of parliament, and I think as the incoming, as the new Minister of Primary Health Care, there are attempts we have in the pipeline, there are plans we have in the pipeline to sensitize the members of parliament, and then it all goes down. I told you about the National Fitness Day. I think it happens once the second week of July. All those are attempts at creating awareness. But also institutions of government, ministries and agencies have been asked to promote physical fitness drives, not only for cancer, but cardiovascular diseases. The Ministry of Health, sometimes when I'm leaving late, about 6, 7 o'clock, it's common to see employees at a certain part of the compound dancing to aerobics and so forth, and I'm sure other entities do that as well. Now, the question is to also now further take it down to the local population. We have the health educators at the level of Health Center 3, Health Center 4, and the cancer policy to also take it down to educate through our community health extension workers that we are now recruiting. We have about half the country covered so far. NCDs is part of the curriculum. And these workers who are trained for 6 months, and we deploy them to parish level. 2 community health extension workers per parish. Part of their job description is to also do some level of health education and health promotion.
Thank you. Let me read some messages that have come through. One that comes in here says, good evening, Timothy, thank you for the show. Recently, my spouse went for a prostate exam and he was tossed for a whole week with no results. He's yet to plan to go back again. Okay. Doctor will be speaking to us about that, how we can be able to access that. Good evening, Timothy. Thank you for the show. I am Romano from Moroto. My question is, what practical steps can government and ordinary Ugandans take to improve early cancer detection, screening, treatment, public awareness, especially for the people in the rural communities who may not have access to cancer services? Are we investing enough in preventing early detection, or are we mainly responding to the disease? Okay. Thank you for your message. Good evening, Timothy. Thank you for the show. Why is cancer now highly registered in the women? Dr. Jackson will respond to that. Thank you, Timothy, for the show. I'm writing to you from Arua. Very many people go to Mulago for treatment from West Nile, and most of them come back in coffins due to delayed treatment or attended to by different doctors there. Okay, very sad to know. Lastly but not least, good evening, Timothy. Thank you for the show. The moment people get back to the real traditional food and avoid genetically modified foods and any chemicals sprayed crops, the person will likely avoid contaminating and getting cancer. In my home, being a typical Luo, for 17 years I have been eating OD on every food that is including porridge. I strongly believe that it's highly able to help me fight all these things. Why has cancer become a terrible issue with everyone today? And in the 90s, it was not like this. Okay, this is a person from West Nile writing a lot and talks about recommendations. Finally, good evening. Thank you, Timothy, for the show. Great job to be able to give us this knowledge that we need. Will it be possible to get cancer hospitals in the regional setups? Labs are not available for early checkups in our regions. Okay. I think some of these have been mentioned or have been talked about, and we'll come back to give details. We're going to come back with solutions, but also to talk more about awareness and also the cancer run that will be happening on Sunday. This and more after this break.
Mami! I want everything, eh? Okay. Yes. So, when I pay the time, this will increase my loan limit. Hey, Momo. Madam, remove the food, put more meat, add the meat. Yes. Hey. Now, these are the fruits of paying your loan is in time.
That's right. Every time you repay your Momo loan on time, your loan limit can increase, giving you access to more money when you need it most. Dial *165*5# to borrow, pay back, and grow your limit with Momo loans.
You have juice?
Yes.
Juice in me.
We don't need anyone's permission to move forward. We never have. What we need is the power to do it our way, to move our people, our goods, our ideas across cities that breathe with our energy. Spiro is not your typical EV company. It's the power grid for African ambition, a network that connects Nairobi to Kigali, Lagos to Lome, Dar to Kampala. Not with cables and wires, but with clean, quiet, relentless movement. Every swap keeps the city running. Every ride links one life to another. We're copying no one else's future. It's we who powers the cities we live in. It's we who shapes the world they'll become. This is Africa, powered by us.
The government's core mandate is to maintain law and order, safeguard citizens' rights, and provide essential public services.
Remember, one of the pillars of a roadmap is innovation and entrepreneurship.
There has been this question of how are you protecting our indigenous seed?
It's going to be a tall project. That answers somebody's question.
For the past 20 weeks, the Front Bench has brought you insightful discussions on governance, security, healthcare, justice, and commerce.
When you go through this complicated procedure, involve the lawyers, you bring the case against him, the judge will hear you out and pass judgment, and you're out of court in record time.
We remain committed to keeping you informed and engaged on key national matters.
So these are huge, these are powerful organizations which now Uganda chairs. Why don't you come together?
If we haven't migrated to the e-card because of various reasons, including that not all the people of Uganda have smartphones.
You can sit in your house, apply for a passport.
If you have a Ugandan
who has a successful logistics firm in the US, it means he can come to Uganda and do a lot more.
Now airing every Monday at 8:30 p.m. with me, Jethro Kasaiji, your interface with the government only on your public broadcaster, UBC, Inspiring Uganda.
Welcome back from that quick commercial break here on Behind the Headlines. My name is Timothy Nyangos. I'm joined by Anne, I'm joined by Dr. Jackson, Professor Balunywa, and the Honorable Minister in charge of Primary Health, Dr. Charles Ayume. Let me read these two messages so that we jump into our conversation here. And most of the messages are coming from upcountry, not from the central. So this one comes in from Serere. It says, thank you, Dr. Jackson and Dr. Charles and the team in the studio. Thank you so much for the show. I have been to Cancer Institute in Mlago like 5 times before I lost my mother, who died to cervical cancer. May her soul rest in peace. How I pray that cancer centers be extended to regional referrals to try and help the common person. You bring the patients with 2 attendants, like from Serere, and there is 90,000 you have to spend every day for review and other things. 2 to 4 weeks you're there and you're constrained with finances. I request that they avail a cancer run kit at no cost. You have jokes. I'm John Bosco from Adjumani. My appreciation for the team that is there, but also the unique information that we're receiving. My question is, can the government make national-wide approach to screening its citizens for cancer for free? Okay. That brings me to the Honorable Minister. Honorable Minister, this disease burden, you have talked about early checks, awareness, prevention. How can government support its citizens, especially in getting knowledge, but also, minus getting the knowledge, getting screening?
As mentioned earlier, is that until about maybe 5 years ago, you had to come to Kampala. The services that were being provided at regional referral level were not adequate enough in terms of diagnostics. You don't have imaging capacity, you don't have adequate lab capacity, you don't have the human resource. And I think that's when government, in its wisdom, it's also enshrined in the manifesto and in the Ministry of Health strategic plan and the cancer strategic plan, was to decentralize. So for starters, we are taking cancer to the regions. And I think one of the things most people are asking, why don't we take it now further down to the districts? But like I said, this equipment is expensive, the infrastructure is expensive. Cancer is not like a theater where you can build an ordinary building and put it there. Atomic Energy Council will come running for you. The standards for a cancer building, the bunkers, are quite expensive. Then you have the equipment, which is very expensive. And then, of course, the staff, the imaging, the oncologists, and so forth. But gradually, we'll have maybe moved to beyond the 4 regions. We may take it further down to the sub-regions. And then cancer education is probably what we could cascade down to the general hospitals, to the health center 4s, and to the health center 3s.
And when it comes to screening, many of the messages are really driving towards screening. And I know you've talked about the regional referrals, how you've come that far, but screening, because as the mapping is showing you, why can't we have screening to be able to look at some of these disease burdens that you're talking about in those regions?
Of course, the first line of screening is the technical competence of the healthcare worker. Even without the diagnostics, the imaging, and the lab capacity, from your basic training, and that's probably where we should come in to the training schools, to the curriculum. Make sure that the nurses, the clinical officers, the medical officers have that investigative mind, because there are sometimes when, not sometimes, many times when we get poorly diagnosed cancer. They'll be treating for A. By the time the patient comes to Kampala from Koboko, he or she is at stage 3, stage 4. So the first point of screening would start from the training side. Second is to build diagnostic capacity at the regional level. That includes imaging, that includes lab capacity. The turnaround time for sending a pathology sample by bus from Arua, first of all from Koboko to Arua, then to Kampala. Then remember, you're getting samples from Budaka, from Chenjojo, from Kisoro. That takes about 2 to 3 weeks. And that is if it's not lost somewhere here in Kampala. So we have to build that regional capacity, and then with time, based on availability of resources, take it further down to district hospitals and probably to health center force. For the screening, I think there have been deliberate efforts. You've seen the bus of Cancer Institute that goes up country to screen for breast cancer, but also things like PSA, the prostate-specific antigen, can be done at, so it really depends on the type of cancer. Pap smears are also done in specific labs. And now that cancer of the cervix, the prevalence is high, as a minister, as Ministry of Health, we commit to ensure that we're going to try and decentralize to ensure that at least you could do PSA at the level of a health center for, and other tests depending on the type of cancer.
And that commitment, what timelines are we looking at for that commitment, but also the other regional facilities you've spoken about? What timelines are we looking at them to be up and running?
I can't give you the exact timeline. You see, the health sector is dependent on so many things, like power. I'll give you an example. You have to have constant power, reliable power, meaning you should have 3-phase transformers. And it's on record that Ministry of Health has put up infrastructure, but it does not function full capacity because of something as simple as lack of a transformer. To have that 3-phase power. It's a sub-region like West Nile. We could not operationalize CT scans until we were connected to the grid. That was about 2-3 years ago. Meaning that the oncology center that is going to be built in West Nile could not have come before 2 years ago, because you can't run the linear accelerators without 132 kVA power, and it has to be constant. So there are a number of factors. I can't put one finger to it, but just know that it's well-intentioned, and as government, I commit as the Minister of State for Primary Health Care that there's going to be work in progress.
Thank you. Professor Holnua, you know, you mentioned children, you mentioned dependents, you also mentioned people that have retired. Those people, when we talk about retired, we talk about children, we talk about the people that are hand-to-mouth, a border rider, a taxi driver. What kind of messaging would go out? How would that message look like to especially create that, that awareness and also kill the stigma that is behind it?
I think maybe just to, first of all, to follow up with the Honourable Minister, they're asking about testing, is it?
Yes.
That may not be necessary among the people who are low risk. You know, I mean, the low risk people who have no exposure to the risks that cause cancer don't need the testing. However, when you go to the genetics, it's usually in the family. That family has a history of cancer. So yes, that may be necessary. So so when you talk about what is the message you want to put across to people,
yes,
is that there are numerous illnesses cancer, diabetes, heart pressure, the common ones which actually attack people, which they understand is pressure and diabetes. And you need to add cancer. To go and say some of these are parasitic, something may not attack you, for instance, if you don't, if you smoke, for instance, you are at high risk of getting cancer. If you drink a lot of alcohol, you are at high risk of getting cancer. If you eat foodstuffs which are overly processed, you are at high risk of getting cancer. So the message to me should be, these are things which may lead to cancer. Avoid them. That should be the message that goes out to the ordinary person to understand. But it's not easy. I mean, it's not easy because many people who retire in formal employment, they know there's retirement, but they never listen to anybody. Until when they retire, towards retirement, they start realizing, oh, I may be retiring soon. And it's a bit too late, especially on issues of health and issues of financial preparation. It's a bit too late. So the message, and to me, this is one to thank Rotary and all those others involved, is that we are saying, even at this show, we are saying, let people know that cancer is real. Cancer is very painful. And cancer can get anybody, but more of those who are exposed to a number of risks. And those risks we should know. You know, we should be able to say, look, stop eating chapati made out of cooking oil which is recycled. I've heard that some cooking oil is got from transformers. I don't know what that means. A transformer? So you definitely you're putting cancer into your blood. So the message should be, avoid these things which are likely to cause you illness. And those illnesses are not restricted to cancer, but diabetes and pressure. And of course, also to say, this is not witchcraft. It's not witchcraft. This is something that is real, it's biological, which is emerging from people's behaviors. So that's what I've seen.
Professor, you know, you mentioned the chapati, you mentioned the oil, but the standard of living also is tough. If you wake up any morning from any direction in this city center, yes, you will see people trekking into the city center.
Yes.
Some people that are not even sure of what they're going to get from the city center, but they're hoping they'll get 5,000 shillings, and the Rolex is about 1,500. Any part of this country. How do we solve that question of standard of living? Because your messaging is you can prevent it by not eating a chapati, but how do we speak a message around standard of living?
Well, of course, you're going into challenges of unemployment and the type of employment. People start businesses when they see opportunities. People start businesses when they have nothing to eat. And depending on what they earn out of it, they correspondingly take a decision on what they're going to eat. I usually host some Dutch students in my residence in Iganga who go to do internship in hospitals. And the Rolex is one of their foodstuffs they like eating. But once you tell them, look, the oil may not be so good, they stop eating it. But then they say, it's so tasty. You know, it's so tasty. But they stop eating it when they realize that it is risky. So I don't know, maybe I can't say the ministry will come and say stop cooking Rolex, but can we control the oils that we are putting out to use to cook?
My final question to you, Professor.
Yes.
You know, the Honorable Minister mentioned about, you know, setting up this facility in West Nile. 2-3 years ago, there was no power. when power comes, that's when the facility can come. How do we get a collaboration with these agencies, with these ministries, to know that the focal point is this facility? Let's all pull our energies towards it. Water, electricity, to ensure that we're safeguarding our people. How do we get them to collaborate and see the greater good than just silos?
I think, first of all, can this be a culture in our education system? A culture of people being aware that as they grow up, that at some stage you may get a cancer, you may get diabetes, you may get blood pressure, and many other things. So if these young people are educated and as they grow up they know what it is, it's going to become easy when I become a medical doctor and there is somebody else to know that we must solve that problem together. So you avoid the silo by building a culture of collaboration and having a common purpose to what you're trying to achieve.
Okay.
Yes.
Let me come to Dr. Jackson. Doctor, what are the biggest drivers of cancer treatment? Where is the biggest cost for a patient and their tenant?
Yeah, I think that's a very good question. We should look at it from the perspective of institutional, and then from the perspective of the patient, who is actually the consumer. From the perspective of the institution, I think as a country, one of our biggest drawback has been lack of capacity that has been built over years, and that is why the emphasis of government right now is putting up the infrastructure and then making sure that we have trained human resource to handle the customer, if I may say. So then coming to the patient, right now, if you are within the government system created through the Uganda Cancer Institute, the most important asset that you need is something which will make you to access our center in Kampala, and then make sure that you remain in care. And actually, our finding is that what prevents people from accessing the services which is there and then maintaining in the care are the socio-economic barriers. Those are the things like, for instance, I don't have where to stay when I'm in Kampala. I don't have what to eat. I don't have transport to go to Kampala. Those are the barriers that actually need to be removed. And that is partly also the reason why in its wisdom now, government is saying, let us put the regional centers so that we can mitigate some of those barriers. We will have the infrastructure there, we will have the personnel there, and the center will be closer to the public. And of course, there are some other ripple effects that will come as a result of that. These centers will by themselves actually now constitute foci for messaging, foci for awareness creation, and then also for training, especially for the lower health workers. As I stated earlier, part of the problem has been because there is lack of capacity to understand complex diseases by the lower health workers. So you can see that by just doing that, we are trying to kill many birds with one stone.
One of the things that the person who sent in a message mentioned there is the hurdles, the red tape, the hoops of going around, get a test here, get imaging there, and they feel like that is a burden. But before we come to that question, the medication for the patients is a little bit pricey. What innovations or solutions do you have in place, or are you innovating to be able to lessen that burden on any Ugandan?
That is a very good question. If there is one innovation that our government has come up with, which possibly is also causing the influx that we are seeing of patients, including those coming from outside of the country, is the fact that essential anti-cancers are available, and that is simply because there is now a mechanism which makes it easy for us, using just meager resources, to work with manufacturers to kind of avail medications to us. And that has actually driven our availabilities for what we call essential anti-cancers to up to 85% and free of charge to Ugandans. So the only thing that is now needed is for our patients to show up. So that, to me, is an important innovation of government which needs to be recognized. And it has actually eluded very many of our neighboring countries because they do not have a system which can actually do that.
You know, having you here means that we have to milk everything out of you for the public to benefit. There are stereotypes, like Professor was talking about, witchcraft, all these things. And some, like there's been a drive about really vaccination against cervical cancer. And some have this stereotype that the young girl will not give birth when the time comes. How do you clarify on the stereotypes that are there to give clarity in what some of these things are?
A very good one. I think those are the misinformation, and part of them, they come as a result of our cultural mindset, which we need to actually fight. And as the Honorable Minister said earlier, some of these things, when you cannot directly fight them, you make sure that you indirectly bring them closure. So within the Uganda Cancer Institute now, we have also now started as a research project trying to understand how we can work together with some of these traditional practitioners, and then also some of the people who use alternative medication, to see how side by side we can actually use the information that they can give us, and then they can also be receptive to what we tell them, so that they can also take the same message to the population. So that is still work in progress, but it is partly to address the problem that you are mentioning.
I liked the free medication. We'll come and delve in that a little bit more, but let me come to Anne. Anne, it's been 15 years. Ugandans want to know, for the last 14 years, all this money that you have accumulated, 8 billion, 9 billion there, what has it done? Is it visible that we can touch and feel what you've been doing? Account to us where it is.
Of course it has. As I said at the beginning, we have established a cancer center in Nsambya Hospital. So anybody who goes to Nsambya Hospital, the cancer center is there. It is functional. It offers cancer treatment for cancer patients. But in addition to that, we also have other projects. Like I said, we have the blood bank in Mengo Hospital, whereby you can get blood, different components of blood for cancer treatment. That is also tangible. Our most immediate task now, and for the bulk of money that we have raised, is the establishment of the radiotherapy center. And as the Honorable Minister said, it is not putting together, the structure for the bankers is not an easy thing. You have to keep working with the atomic energy people, because it's very complex with very specific technical specifications. So that's our immediate task. And we are hoping that by December 2027, we'll have completed that superstructure for the bankers. Now, after that, after 2027, December, then our next task is to equip the center. And what we're hoping to bring are the LINAC machines, the linear accelerators. As a matter of fact, I read somewhere that according, I think, to WHO standards, you should be having one linear accelerator to 1 million people, or something like that. And I think we have 3 in the country at the Uganda Cancer Institute. So you can see a huge gap. Now we're hoping that 2028 onwards, we will bring 2 LINAC, the linear accelerators, and have them at our radiotherapy center in Nsambya, alongside other equipment, of course, to support with diagnosis. Now, after that, or alongside that, we'll also engage in capacity building for oncology staff. We don't just need the oncologists, of course, those are highly technical people, but even oncology, nurses, and all the lab, people. So we'll engage in the training. So those are our immediate, or shall I say midterm, between now and 2028. That's what we're thinking about. But beyond 2028, and in response to the National Cancer Action Plan, we are hoping to complement government's efforts, particularly in the regional centers, through awareness creation. Like I said at the beginning, we have our outreaches, we have our medical camps. And we are going to use that, we're going to continue using that to create awareness on prevention of cancer, identification of symptoms, referral on where to get help. Fortunately, we are now going to have regional centers, so it becomes easier because these outreaches go across the country. We have the medical camps across the country. And I think the beauty about the camps, one of the things about cancer, beyond the cost, there's a lot of stigma around it. And by integrating it in these medical camps, we're hoping that we will be reducing stigma. First of all, people come and, you check for all sorts of things. We're also reducing the cost because sometimes it's just the cost. And we're just making it a routine check. For example, breast cancer and cervical cancer. You make them just part of the routine screening. And so it becomes easier, and then we hope that after that we can then refer those who need additional care or additional diagnosis to the regional centers that will have been established by the government. But for now, our most immediate call is for the cancer run that's happening on the 30th of August. And I'm appealing to everyone out there to join us. Our target this year is to have 80,000 runners. And previously, we've had the cancer run mostly concentrated in Kampala. But this time, we're going to have the run in all the major towns across the country. So wherever you are, whether you're in Gulu, whether you're in Arua, Kabale, Ntungamo, Mbarara, Jinja, Mbale, we will have runs in all those towns. And so we're appealing to each and everybody to come and join us so that we can start what we finished, we can finish what we started. And the most important thing is to complete those bunkers. So I'm appealing to you all, please come and join us on Sunday, 30th August.
Dr. Jackson mentioned something about, feeding, living areas for the people that are attendants to these cancer patients. Is that something that you are considering, especially as Rotarians, to ensure that you're having a whole ecosystem taken care of to facilitate that the patient is not worried about what he's having? Because you can decide to, let's save the money instead of me going to hospital, to leave it for the family. How do you support that ecosystem to support the patient?
There are many, many players in this area of cancer care and treatment. For example, there is the Uganda Child Cancer Association, Foundation. Now, they're focusing on some of these things like care, nutrition, accommodation for children affected by cancer, many of whom come to Mulago. And so as Rotary, we won't take on everything, but we can support these other organizations to do the work that they have chosen to do. And so some of the contributions, for example, that come to the Rotary, through the Rotary Cancer Run, eventually some of that could be channeled to these other organizations. There's also the Uganda Cancer Society, that's also a partner of ours. So we work with different partners and we can support each other without necessarily taking on each and everything.
Thank you.
Yeah.
Dr. Jackson, there are numbers that are thrown around, 35,000 annually, increases this much. What are the actual numbers, and what are you doing to, what targets do you have as Uganda Cancer Institute to bring down those numbers?
Yeah, thank you. What you're talking about are the figures we call a burden of cancer, and we look at mainly incidence, we look at mortality, and we also look at prevalence. But now also growing, people are starting to look at, how it affects quality of life and all that kind of thing. So you need all those parameters, you need to reduce them, or you need to improve them. And of course, there are also indicators of what your services are doing. For instance, if you are doing well, we would expect that survival would improve, mortality would be reduced, and that means, of course, those who have already been diagnosed with cancer, who are now living, you can call it, with cancer, their numbers should also go up. We call those survivors. We need to improve on their well-being. So if you are to have all that in place, the entire system, what we call the National Cancer Control Plan, must be implemented as is. And actually, that is why my appeal will be that the meager resources that we have for the cause must all be consolidated, guided by that plan, so that at the end of the day, the outcomes which are measured by those factors that I've listed improve. So if we do that as a country, that is when at the end of the day we can say that we are actually making an impact on cancer as a disease.
Are we into innovation and solutions, especially in terms of medication? Are we doing that? What does that look like? And how much does it reduce your meager resources in terms of that burden?
Yeah, so the most important innovation is to improve on how we use the medication. For instance, we are moving away from just looking at one patient per medication. We are looking at, for instance, compounding as well as mixing of medicine in bulk, so that we can just take aliquot for treatment of patients. And in that way, you'll find that if you just had one vial of a drug, you can actually distribute it among a number of patients, and you avoid wastage. So those are some of the innovations that we have, and that is partly the reason why we have better availability despite the meager resources that we have in the country.
Thank you. Professor Olunywa, local leaders are a very big influence, especially on the population, come from the LC1, LC3, mayors, especially all the political heads. How do we rally everyone to come against this burden so that we are all championing behind this to ensure that we have longevity of life?
We've talked here and we've not talked about, I know these doctors normally don't want to talk about local hubs. I have had situations where some people have taken sour soap, Staferi, and they've improved. In my compound, I have lots of trees, and many people come to me, oh, this one does this, this one does this. And the Staferi, the sour soap, is famously one of the things that are supposed to be, anti-cancerous, so supports cancer people. So when you talk about local leaders, and I would suggest the minister, this is something that needs to be researched into. Me coming from the academia, I think it is important that we know what is the impact of the usage of local hubs, because I know many people come for the leaves of my sour soap, and use it for, to treating cancer. And even the fruit itself, the chitaferi fruit itself, and its juice. There is also, incidentally, somebody was telling me that they use, I think, is it marijuana or something like that? Yeah, cannabis. I think it's important for the minister. These are things for research. So as you talk about local leaders, what are some of the local solutions, and can we pursue them? Can we follow them up and see? But I think the Rotary and some of the activities they do in various towns could be one of the sources of letting the local leaders know that cancer is a problem. Cancer is something that maybe is a leading killer actually in the developed countries. With us, we haven't got there yet because we have a very young population. And for those who live in the countryside, maybe they have not been affected that much. So local leaders, I think, to me, possibly we have in the villages people called what's the name of those village VHTs? Yes, VHTs should be educated about cancer, like the other diseases. I didn't know about these people until recently. There are some people in the villages who go out to support others, technically in the medical field. So that is the vehicle to deliver the message on cancer and indeed any other disease.
Thank you. Yeah. Honorable Minister, I know you want to respond to something that Professor said, also national insurance. But let me add this question. What is our reach of palliative care in the country, especially looking at how expensive it is for this disease?
No, we have, there's access to palliative care. But it's mainly strong at hospital level. We're now trying to ensure that our policy cascades it further down to Health Center 4s and Health Center 3s. And the main limitation would be recruitment of what we call palliative care nurses. But in terms of access to morphine, when we were making the law on narcotics and psychotropic drugs, we had to ensure that because there was a challenge of who should be able to dispense morphine, and we thought that if we limited it to doctors, then what would happen in the rural setting? So we kind of opened it up to, I think, the level of nursing officers to make it more accessible, because it's also a bit controlled. We don't want any person to be able to dispense it. So in terms of palliative care, yes, there's a limitation. It's still at the level of hospital, but we want to cascade it further down to Health Center 4s and Health Center 3s. That's in terms of having the right people there, the palliative care nurses, but also accessibility to morphine. But maybe just to rejoin that where my colleague Professor left, we have community health extension workers, like I had mentioned earlier. Those are above VHTs, and they are deployed to parish level. So 2 community health extension workers per parish. You have to have, unlike VHTs, some who are opinion leaders in the community, they can rationalize issues and translate certain things. These ones have to be literate. They should be able to read and write. You should be able to you're trained on how to use a tab. It's a 6 months training program. And your minimum qualifications is a senior force certificate. So you're trained for 6 months and then you're deployed. And of course, one of the key areas that they are trained on is NCDs. So they are part of our, in addition to the VHTs, they are part of our early warning systems, whether it's for epidemics, but we are also now using them on the aspect of NCDs. And yes, like I mentioned earlier on, we have the Traditional and Complementary Medicines Act of 2016 that, one, recognizes herbal and traditional medicine, but also, two, regulates the space in which they should be able to operate. And as a ministry, we have a department of natural chemotherapeutics. So any Ugandan who feels that they have a recipe against an ailment, against a disease, you can take it there and they'll be able to isolate the ingredients. And we, of course, we are alive to the fact that most medicines come from plant extracts, like the quinine is from the chichona tree that was discovered in South America, artemisinin and so many of these. So, but the problem is some people who have this knowledge, for fear, I think, of people think their formula will be plagiarized and all that, they don't want to step forward. They don't want to come, and for us, we shall help you isolate so that you're able to add value and market it. And I think that's where India and China have beaten us. Us, I think we are still in the 19th century. We don't want to pass this knowledge down, and we also think that other people will steal it. But I would want to encourage the herbalists who are out there, come forward. The ministry, we have a good lab, we'll help you isolate these things. And finally, the Uganda Cancer Institute in the East African region is the center of excellence. And when you're a center of excellence, research and development has to be a very key component. So they are not only for diagnostics and treatment. There's also once that building at Mulago Hill is complete, there'll be a huge component of research and development, and that includes what new drugs are out there, what new diagnostics are out there, and I think probably in the next 3 to 5 years, the landscape of cancer research and development, diagnosis and treatment will have taken full shape. And there's already testimony to that. When you have 20% of the cancer patients at the Uganda Cancer Institute being foreigners, I think that shows that there is belief in the region. People are accessing the drugs. But of course, when one thing goes wrong, then there is a lot of bad publicity. But I would want to encourage Ugandans, stay steadfast. We're on the right track.
Thank you for the vote of confidence. But let me read some messages so that I'm able to give you parting shots. Good evening, Timothy. This is Dr. John Moody, watching from Juba, South Sudan. Good to see my OB, the Honorable Charles Ayume there. Thank you for the nice program on cancer awareness. The people who present late cancer diagnosis, what is being done to ensure that early detection and treatment, especially in the rural areas, the remote areas, is dealt with there? Okay, thank you. Thank you for the show. Good evening. Thank you for the great job to care for us. Will it be possible for us to get cancer hospitals in the region set up, labs and all these things? Okay, thank you for the question there, and I think the minister answered that. Good evening, Timothy. Thank you for the show. I want to thank the creation of this awareness. My request is, if government provides more machines for radiotherapy, I was there in February, March this year before I lost an elder brother in April. The ratio of people who need the service was too much. It was also selective. It's really bad to see what happens there. This is Ezra in Bizwera. Okay, thank you, Ezra. This is Okech. He says, cancer is like corruption. When corruption is finished, there will also cancer will be finished. Really? Good evening, Timothy. I do not know if I came in late. I would like to get wisdom to give us some clear elaboration on the main causes of cancer. It will help us to prevent it. Okay, thank you for that. Lastly but not least, how can we all work without the cancer policy? Let Dr. Ayume table it in Parliament. Once people get cancer, they are replaced at work immediately. For those who have managed to go back, they are isolated. In fact, most people are not dying of the disease, but rather of the humiliation and the stigma at workplaces. I'm a victim of that, and so many of the patients like that. I think the person is talking about stigmatization there. Thank you, Timothy. Please report to the ministry or the minister that the Health Department of Public Health Education never aired information about Ebola and Uganda's Ebola-free campaign. Thank the doctors for the information they've given us. Once in a while, we saw it on UBC. Can the Minister of Health and the Cancer Institute do this every 6 months, every once in 6 months to have this information? Okay, finally, Timothy from Mutungo says, I'm watching you. Thank you for watching us, and we'll leave it at that. So many messages that have come through. I will start the parting shots with Anne, Dr. Jackson, Professor Balunywa, and finally the Honorable Minister.
Okay. The Minister was speaking. I actually thought there's so many things that our local leaders could do. We have many regulations that are not being enforced. In my reading of cancer, one of the risk factors, and one that would work for even poor people, is to reduce alcohol. Because alcohol consumption, and I say this very carefully, it is a high risk factor. But we have regulations that could be put in place just to reduce consumption of alcohol. We have regulations that could support disposal of waste management, of waste, plastics especially, because we're taking a lot of microplastics in the water and things that we take. So if each and every one of us, wherever we are, played our role, I believe that we would be able to reduce the cancer burden. So my ask to everyone, play your role.
Thank you. Over to Dr. Jackson.
Yeah, so thank you very much. To me, my parting shot will be really a reflection, and this reflection is also, I would say, really a gratitude to our government, because the approach that Uganda has taken in the fight against cancer is a very novel approach, which is very effective, and it is also having an element of equity that most countries actually do not have, whereby you find that we are in the middle of a big problem, but we are handling it very holistically. Treatment is being given in a very effective manner. Messaging of prevention is actually increasing. There is within that also innovation coming up, how to handle this big problem. And then already we are beginning to see results in that, people are accessing care, and actually outcome is improving. And all this by just simply implementing elements of the National Cancer Control Plan. So to me, I think this is something which we need our population to understand and to know that actually great things are happening here in Uganda in the fight against cancer.
Thank you very much. Professor?
Thank you, Timothy. First of all, I want to thank Rotary for this sustained effort in creating awareness. I think the awareness needs to go a little bit more into communities. My worry is about many of us who retire and have not planned well, and to the extent that we actually we are prone to cancer as you age, because it's one of the causes. That it's important that employers talk about retirement and cancer and all these diseases as part of the talk to staff. I would also think that we should institutionalize advice about health right from the young age of people, that people can keep good health up to the time they retire. it makes retirement much easier, and you are likely to avoid such problems. Now, for the ordinary people who may not even know about cancer, who take use this oil and all these other things which they don't know about. I mean, burning Buvera, for instance. People go out, collect Buvera and burn it and expose themselves to cancer. I mean, there's need for public awareness about this, and I suggest that Rotary should incorporate some of these things in the activities. The Ministry of Health too should also talk about this. Yesterday, I think I heard about, either on TikTok or somewhere, somebody was talking about stop burning Buvera. They're dangerous for you. So there is need for that concerted effort from the different players that cancer is real, it will get you. Lastly, I hope that the cancer ward in Zambia is friendly, pocket friendly to the cancer patients. I mean, how do I take a decision to go to Mulago or to go to Zambia? Is it because I have some more money with me, I'll go to Zambia? If I don't have the money, I'll go to Mulago. I hope that Rotary makes sure that this facility is accessible to people who have lesser incomes, and is complementing Mulago in terms of addressing our challenges.
Thank you.
Thank you.
The Honourable Minister, finally.
Thank you very much, Timothy. I really feel the pain of patients, caretakers, and families that have lost people due to cancer, or whom they are still managing with cancer. I'm a member of parliament from Koboko municipality, and many times by the time people reach out and we send cancer patients to Kampala, unfortunately they're in stage 3 and stage 4, and most of them go back in a body bag when it's too late. So there are issues to do with awareness. Part of it was maybe witchcraft, but also the low diagnostic capacity, screening and management, but also training of frontline workers. So as on behalf of government, I commit that we'll address some of these things, not only for Koboko, but the entire country. Some of it is work in progress. We have already talked about regionalizing. There's training. As Parliament, we appropriated money for recruitment of staff for the Oncology Center in Gulu. All these centers come with a minimum of 100 people, and most of these are clinicians. But that said, we need to, it's a whole of government approach. Some of it can not only be left to the health sector, because as we are getting the downstream issues, we talked about food. I talked about a bill that was laid yesterday. How do we ensure that we take very good care of our food? How do we ensure that the girls who are 10 years old go and access the HPV vaccine? So I think we need to put all our hands on deck. I said where we are positioned as a country, we offer clinical care to our neighboring countries like Eastern DRC, South Sudan, and those put a huge strain on the cost of care. When we get drug stockouts, in the spirit of Pan-Africanism, we can't say, hey, because you're from this country, please go back or get off the bed. No, we are bound, we are duty bound as doctors, as nurses, and other clinicians to treat. And that's where now comes in health insurance. It's a form of gatekeeping mechanism. If you went some of these neighboring countries like Rwanda, you just can't walk in and get treated. They'll ask you for insurance. But I also want to tell Ugandans that it would be portable. If I get a problem across the border, then their insurance fund would bill our insurance fund, for example, if there was one already in place. So let us not fear the issue of health insurance. I think because of economies of scale, we would be able to raise domestic financing to be able to cater for the deficits that we are seeing in the issues of our budgets. The HIV journey has shown us that it's possible. When HIV was sacred and being managed by specialists, it cascaded further to even nurses, beyond medical officers, beyond clinic officers, to even nurses. So I think the future is bright. And for the last 30 years, what was on our menu was HIV/AIDS, tuberculosis, and malaria. And that's how the Global Fund actually came into enforcement, because those were the most pressing issues. But now, 10, 15 years ago, we saw the NCDs, cancer. So we have changed our shift as government. Not forgetting that, yes, we're tackling NCDs, but the communicable diseases are there. Malaria has not gone away. HIV/AIDS has not gone away. So our budget as a sector, as a government, is stressed. But there's no cause for panic. We have realigned ourselves as government, and give us some time that we're going to plug our holes. We're going to plug some of these holes, and the future is bright. Thank you very much.
Thank you very much, gentlemen and lady. Thank you for coming to discuss such a patent issue. And for you who has watched us up to this very hour, thank you so much for watching us, the production team for making today possible. But we'll end this show with asking you to step out and go for the cancer run on Sunday, 30th there. In whatever district or region you're in, just find out where it is. A vest is at 30,000 shillings. And let's come behind such a cause to make sure that we have more people that survive from cancer all through the year. From us to you, good morning and have a fabulous day.